Assalamu alaikum. Now I would like to talk about plasma cell dyscrasia or plasma cell disorder. Starts with this multiple myeloma. This is the skull X-ray of a patient with multiple myeloma where there is punched out lytic lesion present in multiple myeloma, punched out lytic lesion. All you have to remember in multiple myeloma, that is the Kraft feature, that hypercalcemia, renal failure, anemia, and bone lesion, bone lytic lesion. And if you get a patient with this Kraft feature associated with skin rashes, you might consider that this patient might have adult T-cell leukemia or lymphoma. In multiple myeloma, there is malignant proliferation of the plasma cell in the bone marrow, and in here there is high serum IL-6. There is high serum IL-6 is sometimes present, which stimulates plasma cell growth and immunoglobulin production. What happens as there is lytic lesion in the bone? How this bone lesion happens in neoplastic plasma cell? Neoplastic plasma cell activates rank receptor on osteoclast, leading to bone destruction, and that is causing this punched out lytic lesion on skull X-ray. Usually skull and vertebral X-ray, you see this feature. There is other thing you have to remember, that in there is elevated serum protein. Neoplastic plasma cell produce immunoglobulin M spike is present on the serum protein electrophoresis. M spike is seen in serum protein electrophoresis, and most commonly due to monoclonal IgG and Ig. In here there is IgG and IgA production, but there is M spike. This is the normal serum protein electrophoresis picture, and this is the M spike. This is the M spike, which is present in where? Can you say? This is present in multiple myeloma, and there is increased risk of infection because there is lack of antigenic diversity. If there is lack of antigenic diversity, we know that antigen can change its diversity and can form IgM to IgA. When it needed, it can convert into IgA, it can convert into IgG. But if there is lack of antigenic diversity, it will not gonna destroy the infection, and infection is the most common cause of death in multiple myeloma. And there is rouleau formation. This is the picture of the rouleau formation. Of RBC on blood smear. Increased serum protein decreases charge between the RBC. Charge RBC. And another thing you have to remember, there three things. There is overproduction of light chain, and light chain accumulates. Free light chain circulate in the serum and deposit in the tissue and causing primary AL amyloid. And these light chain goes to the kidney and causing renal failure, which is called myeloma kidney. And this free light chain is passing out through urine, causing proteinuria, and it is called Baines-Jones protein. This is the most common high-yield words you have to remember in multiple myeloma. If you get a patient if you get a patient without having the craft feature, there is only isolated isolated M spike, then you can consider this patient as monoclonal gammopathy of undetermined significance. It is seen in 5% of 70-year-old individual, and 1% may develop multiple myeloma each year. And in the next disease is Waldenstrom macroglobulinemia. There is B cell lymphoma with monoclonal IgM production. On the other hand, in multiple myeloma there is IgG or IgA production. On the other hand, in Waldenstrom macroglobulinemia there is monoclonal IgM production. And there is generalized lymphadenopathy with lytic lesion in the bone. You will get M spike, and there is visual and neurological deficit, retinal hemorrhage, stroke, and causes serum hyperviscosity. There is bleeding. Viscous serum results in defective platelet aggregation. Acute complication is treated with plasmapheresis, which removes the IgM from the serum. Now I would like to talk about some disease which is not that important, but you have to know that. One is Langerhans cell histiocyte. In Langerhans cell histiocyte you may get this tennis racket shaped granules, which is called Barbeck granules. It is seen in, this is called Barbeck granules seen in Langerhans cell histiocyte. If you see Barbeck granules, you have to immediately think that this is Langerhans cell histiocyte, because if you try to remember by other thing, it would be hard for you. And it is S100 positive. It is S100 positive. S100 is positive also in schwannoma. And there are some other disease called Letter-Sui disease and eosinophilic granuloma at hand, Scharf-Christine disease. And Letter-Sui disease, there is two names. So there is malignant proliferation of the Langerhans cell, there is skin rash and skeletal defects, and in hand Scharf-Christine disease there is three names. So there is scalp rash, lytic lesion, lytic skull defect, and diabetes insipidus. And in eosinophilic granuloma there is benign proliferation of the Langerhans cell in bone. As there is no name included, so this is benign, and the rest of the two is malignant. And that's all for this. Inshallah you will be benefited.